Barua sir.
Please.
Barua sir.
Yes, please.
DME sir call করিছিল জয়েন কৰি আছে sir.
Okay, okay, that's fine.
Barman sir, good evening.
Good evening. What's a Bormon? I heard Bormborua.
Hi sir, Barman sir, শুনিছে? Barman sir, আপোনাৰ অডিওটো মিউট হৈ আছে sir.
Can you hear me now?
Yes, yes sir. Good evening sir. Good evening.
Good evening. Good evening.
Barua sir.
Yes, please.
We'll start sir. Start কৰো sir. ঠিক আছে. Okay, good evening to one and all present in this Zoom platform. On behalf of Assam Downtown University, I welcome all the respected panel members, all the participants, delegates, and the audience, whoever is present here, to a very important topic discussion, that is the reforms in healthcare education and in industry found in the post-COVID-19 scenario, the challenges and the opportunities. So we all know that we are facing a situation which we have termed as a new normal, which are using this term, and to cope up this new normal, we are trying our best to come up with different strategies and different challenges with solutions. both at the education sector, at the industry front, for the hospitals which are running in this tough time. So today we have chosen this topic in the healthcare education because as an university, Assam Downtown University, and as an education institutions around the state, all over India, actually all over the globe, are facing challenges of this digital transformation and how to move ahead with this new transformation for the students as well as for the faculty members. Same goes for the hospitals which are running in this tough time, the protocols, the new arrangements, how the hospitals are running, and how the government is trying to tackle the situation to combat the pandemic. So considering this need of hour, today we are actually honored and privileged that we have 4 eminent panel member speakers with us. And they are, first I'd like to say Professor Dr. Uden Barua sir. Welcome to the program, sir. On behalf of Assam Downtown University, I welcome you. Then we have with us Dr. Anup Kumar Burman sir, presently the Director of Medical Education, Government of Assam. Sir, a hearty welcome to the program. We have Dr. Gayatri Bezbarua, Professor, Department of Pediatrics, Guwahati Medical College and Hospital, Assam. Welcome, madam. And we have Professor Dr. Ankumani Saikia, the HOD, Department of Community Medicine, Government of Guwahati Medical College Hospital, Assam. So before we move ahead with this discussion and the today's topic, I would like to, in brief, give an introduction of our respected panel members. So first, I will start with Uden Barua sir. Professor Dr. Uden Barua, who is an MD, FICOG, FIMS, and FICMCH, retired Executive Director, Medical Services, Oil India Limited, and right now working as a Medical Superintendent and Gynecologist, Downtown Hospital Private Limited. Sir has done the MBBS in Dibrugarh University, MD in Obstetrics and Gynecology from Dibrugarh University, a short-term management training course at IIM Ahmedabad, Diploma in Gynecology Endoscopy, University of Kiel, Germany, management training at Harvard School of Public Health, USA. Sir has served as a consultant and a superintendent, Executive Director, Oil India Limited, also as a Registrar, Royal Infirmary, Glasgow, UK, Medical Officer, ONGC Hospital, Sibsagar, District Gynecologist, Tura, Meghalaya, and at present, he is associated with us as a Medical Superintendent, Downtown Hospital, Guwahati. Sir has a number of fellowships like Indian College of Obstetrics and Gynecology, Indian Association of Gynecological Endoscopists, IMA Academy of Medical Specialties, Indian College of Maternal and Child Health, National Association of Voluntary Sterilization of India, Endometriosis Society of India, Indian Association of Occupational Health, Indian Medical Association IMA College of General Practitioners. He has served in different roles and responsibilities of administrative ownership at Oil India Hospital, Duliajan, Healthcare and Obstetrics Gynecology Services in oil employees. He was the person who introduced laparoscopic sterilization in Assam back in 1983, conducted training courses on endoscopy in Assam and the northeastern region, worked with ICMR Assam Lahual in hemoglobinuropathy and pregnancy outcome, malaria control in Jorajan project of Oil Assam, President of Duliajan branch of Indian Medical Association, Indian Association of Occupational Health for 14 years, conducted a number of CME programs and conferences, zonal, state, and northeast, presented a number of papers in journal, national and international conferences. He is also associated with several NGOs working in Assam for providing primary healthcare to the underprivileged section of society. He is a member of Quality Assurance Committee, NHM, Assam. Sir, we are really honored and privileged to have you amongst us today as one of the panelist members. You would like to say something, sir? Yes.
Thank you, Abhijit, for your kind words. And I'm really privileged to share this session with eminent speakers like Anup Burman, Gayatri Besbarua, Ankumani, etc. My subject will be basically dealing with the hospital. And to that effect, I have prepared a couple of slides so that I can complete within the stipulated period of time. COVID-19 pandemic has created havoc all over the world. We all know about it. And to that effect, I will start with a scenario in an ICU. This is not uncommon in any part of the world now. And this has been done by this culprit, is COVID-19, which has been named by the WHO. It has affected almost all the countries, and about 14 million people in the world has been affected, and all in India it has crossed 1 million with almost 27,000 deaths. And worst part is that, as per this chief scientist Swaminathan, she said that it's going to stay for some time. We all know about the COVID-19, how it came from China, Wuhan district, from bat to consuming food, then the intermediate host man, and now it is the social transmission from man to man. Although some people say that it has also been created in the laboratory. The pandemic, this type of pandemic has happened in the past also. I have showing this slide just to emphasize that we will also come out of it. Mankind has come out of it. So for instance, plague, we all know the Spanish flu, which also affected India very badly. At that time, 50 million people all over the world were dead because of this. And India also, especially in the Maharashtra, a lot of people died. Now the most important thing, that are we prepared to tackle this problem? One of my favorite writers, Stephen King, he mentioned, there is no harm hoping for the best if you are prepared for the worst. So let us prepare for the worst. And if we become proactive, not reactive, and definitely we'll be able to tackle it. One thing must be understood by everybody, that after now and after this COVID pandemic, business will never be as usual, at least for a couple of years. Now everybody, all hospital establishment has to prepare for surge capacity. Now how to do it? The 4 pillars are: number is space, second is staff, third is supplies, and fourth is the system. Now let us discuss about few words about space. In India, especially compared to some of the Western countries, we had scarcity of beds. The bed is whatever we had, 0.55 per 1,000, as against the 5 per 1,000 WHO recommendation. Although government is doing their best to enhance the bed capacity, but still it is far from adequate. And that is the bed capacity. Second is that every hospital now has to make provision to treat COVID patients. We have to make additional capacity, not only to treat, but to save our patients from the infections if the COVID patients enter. First and foremost thing, we have to keep our front door correctly. Manage our front door. That is the entrance. One entrance, one exit. That is the rule for all the hospitals, not only during this time, but also after the pandemic is over. A lot of investment we have to make to create additional space. Now the most important, second most important, I put it because it is the staff. You can create hospital, you can create bed, you can buy everything, but you cannot buy staff. IMA has given a red alert that 99 doctors have already died. I'm not talking about paramedical doctors. 99 doctors have died during this in India itself. So if this continues, there will be acute scarcity of staff. Already Bangalore, they have closed down 12 private hospitals because there is no staff. So we have to keep the morale of the people very high. And how to do it? Number one, we have to communicate. We have to communicate with them everything, whether it is the bad news or good news. We have to educate them. We have to supply them proper PPE. And another important thing, we have to assure them that if you work during this period, if you fall sick because of your duty, hospital will take care. That's what we are doing. Third thing is the supplies. We all have seen how this scarcity of supplies was created. Whether this is natural or artificial, do not know. It is still being there. Remdesivir is sold at the rate of 45,000, the cost is around 4,000 or 5,000. So we have to ensure that adequate supply chain is maintained all throughout this pandemic. And this system, we may have the supply, but unless there is an SOP, that is a system how to utilize these resources, this will be exhausted. So there must be a system in the hospital how to utilize it. The guiding principle number one is that safety of the healthcare worker, safety of the patients, and no patients must go back from the hospital because of this COVID-19 pandemic with additional morbidity, and worst scenario is the mortality. We must take all precautions. And to that effect, we have to educate the healthcare workers. In addition to the healthcare workers, we have to educate the patients, we have to educate the family, we have the public. One thing we must understand, hospital isn't all healthcare organizations, they are public institutions. So there is a cooperation from the public that we cannot do anything about it. To that effect, how to do about it. I have read somewhere that in Assam, suppose if you want to get public participation, specialists for the social distancing, hand washing, then maintaining hygiene, we have to go back to our culture. We all know about the Neo-Vaishnavite culture in Assam. There is a system that once before you enter your house, you have to wash your hand, we have to wash your feet. The shoe which you are using outside, you are not supposed to take. Similarly, if we go to our Namghar or the places of prayer, there are certain, they have to cover their face, they have to put something on their head, so that this is not transmitted. So if we take this as a cue, we can have total public participation for this control of this system. Now this digital adoption, 3 points I would like to mention. One is the telecommunicating. Suppose we have 100 persons working in a hospital. Those people, those who can work from home, they should be allowed to work from home. And telemedicine and telehealth, these are one of the most essential things, and everybody has to be aware about this telemedicine and telehealth. Then now how to sustain? We all know that footfall in all the hospitals in India has dropped down by 70 to 80%. But at the same time, we have to generate resource so that we can pay our workforce. We have to spend extra for making additional facility, then the sanitization, then sterilization, and supplying of the PP without additional cost. So we have to generate resources. How to generate resources? There are 4 things actually for generating resources in a hospital. There is first one is that small amount, but small people involved. So long we were not bothered about that, but we have to think about it. Again, small amount, a large number of patients. Again, big amount, but small patients. And again, big amount, big patients. Previously, all the hospitals, especially these corporate hospitals, were focusing on the last 2. But now we have to focus in everything. Then the fiscal stimulus. You see, everybody getting fiscal stimulus except hospital. Hospital should be treated as an industry. For instance, we should be given electricity subsidy besides others to sustain during this pandemic. Now, as I have already said, that post-COVID challenges will be much more than the present pandemic. Why? There will be spark of COVID-19 again, as we have seen in India. State of Kerala is a golden example. Then also this administrative and clinical challenges. Say one example that now we are allowing one patient, one attendant, or even no attendant. But after the COVID is over, people will be complacent and it will be difficult for the administration to control that. But we have to do it. A lot of clinical challenges, a lot of new clinical challenges will come, and that has to be overcome. Then all these non-communicable diseases like hypertension, diabetes, they are not visiting the hospital now, but there will be tremendous participation after this is over. And elective surgeries, which we are postponing now, we have to do it after this. how to do about it. One example is that hybrid communication, that is in-person and digital health practice model, where we can use this AI and this augmented reality. And by that, doctors or nurse will screen which patient needs to come to the hospital and which patient they don't come to the hospital. Then social vaccine. I always say that social distancing or hand washing, whatever we call it, this is social vaccine. It must be strictly enforced, and that we have to incorporate. That we can do only when we educate the public. That comprehensive risk communication strategy, this is one of the most important. We have to build trust, and that can be done only by the structured training of the CRCS. Then willful public and engagement, not coercive, but willful, and encourage home isolation to reduce the burden. Revival of the medical tourism. In Assam itself, we used to get a lot of patients from surrounding countries, Nepal, Bangladesh, Bhutan, but now it has come to zero. Now we have to revive that once this COVID pandemic is over. Otherwise, hospital, it will be difficult for them to sustain. Then home care after discharge. This is one of the area. Suppose there is a patient which was intubated, which was in the ventilator, and that patient is discharged. Who will provide the care? Because that patient still continues to need. In this, some PP model has to be ensured. Then there will be some ethical and legal issues. Now the DNR. Suppose we all know about do not resuscitate. There are cases where this is which is being done. Say in Italy, because of the non-availability of the ventilators, they had to select which patient will be benefited by using ventilator. And similarly, which patient needs to be admitted. South Africa, they are returning patients because there is no bed there. But this will have serious legal implications besides ethical issues. Then educational, occupational hazard for the healthcare workers. There is tremendous stress working in the COVID unit for 12 hours. And this stress, not only in the working in the COVID, but also in the hospital. There will be a lot of stress related. So hospital must provide help so that this can be tackled. And medical malpractice should all I have mentioned, this can be done. What we should do after the post-COVID, all hospital must maintain a dashboard regarding the 4 pillars. That is the bed, what is the HS healthcare worker, then the services and supply. These all things, they have to maintain a dashboard, and administrator has to maintain it daily. And we have to define clinical criteria, which drug or which facility to be used in which cases, not random. And strengthening the triage team. The triage team is most important part for selecting, separating the patient from the entrance itself. And triage team, whoever maintains it, the leader must have not only have the clinical skill, but he must have proper communication skill so that he can convince the people and make them understand that whatever being done, it is for the benefit of the patient. And dismantling of the digital adoption barrier and robust digital healthcare system. And these are also very, very important. Then what is the way forward? Make healthcare industry more resilient. How can you do it? Besides others, we have to have this Atmanirbhar. We have to have equipment, pharma products, diagnostic kits, vaccines. Whatever is made in India, we have to have all the healthcare institutes must give proper support. And together we can conquer the pandemic. Thank you very much.
Thank you, sir. Thank you so much for the wonderful presentation and giving us the insights of how to combat this pandemic and what are the important points. So now we will quickly move to our next respected panelist, Dr. Anup Kumar Burman. So I will just give a brief introduction. He is MBBS, MD Medicine, DM Nephro from All India Institute of Medical Sciences, New Delhi. Formerly professor and HOD of nephrology, Guwahati Medical College in Guwahati. Currently officiating as the Director of Medical Education, Training and Research, Government of Assam. President of Assam Council of Medical Registration, member of Medical and Health Recruitment Board, Assam, one of the Board of Directors, Assam Medical Services Corporation. Sir, a hearty welcome on behalf of Assam Downtown University, and we are really thankful that you could spare a little time out of your so much busy schedule, which we know what is the scenario now and how much you are busy with the protocols to combat this situation. Over to you, sir. Sir, your mic is in mute mode.
Yeah, now I'm audible now.
Yes, sir. Thank you, sir.
First of all, I must thank the organizer for Downtown University for giving me this opportunity today to be here with this webinar. And I also congratulate the Downtown University for holding such a beautiful and needed. In fact, it's a very need of the hour for discussion about these issues. And already the Burwa sir has nicely overviewed about the current scenario in COVID pandemic. And this is really a very unprecedented pandemic for us. And this is, we don't know exactly how long we have to fight with this pandemic. And currently, although we are coping up, we're doing, Assam is doing, even talking about from my government, actually Assam is doing well so far. But we do not know exactly what will happen in the future because the prediction is very, very high as of today, as we got it from the government of India, that this it may go up and up now again to August or September. So far we are doing well, as you all aware. Our even in private hospital also giving us a lot of help in combating this disease. But we also need a support, full heart support from your end till the end of this war. So in that, at this hour today, basically to discuss about the reforms in the healthcare educations, and of course in the industry in the COVID era. And really it is a challenging, and as I said, and it is really a very difficult task for us because to contain the disease, most important is to avoid the crowding, most important maintain the social distancing and the less people gathering. So you all know, but for the doctors and the healthcare workers, it's not of course applicable, but still we're trying to manage our human resources in medical or in healthcare. But I'm telling you, it is very, very difficult to maintain. So details how we are maintaining will be, I'm sure we have two eminent speakers from the medical colleges, Professor Gayatri Bezburwa, she is a pediatrics, which is a professor of Department of Pediatrics. And also we have one of the very eminent public health, Dr. Ankumani Soikia, she is also professor of community medicine. And they are working day and night for this training and for these various in line to combat the disease. So definitely we'll happy to hear from them. But my just to beginning, I will just start with few words only because I'm not preparing any slide today. So I will give some comments on the issue what we are facing. The most important comments is that developing a societal need-based feasible medical education system is itself just very challenging task as on today. And a common criticism, as you all know, there is a common criticism against the present medical curriculum, and that it fails to inculcate the appropriate skill and competence among the learners to serve the community. This is the common feelings by the general peoples actually. But it may not be true in most of the time. But so far, this is a feeling of the general population, but we have to accept it. So therefore, but what is the task in our hand is we have to develop a very effective healthcare delivery system. We have a definite some structure in healthcare delivery system. That is basically to ensure a universal access to health for each and every person. I'm not talking about our COVID, I'm talking as a whole, because this is a very important background. With this backdrop only we are working on it. So to say that it is a very important for us that so that we can give a very impart a quality medical education. So how we can impart a quality medical education to our graduate? so that they can come out a quality doctors to serve the people of the Assam or to people of the state or people of the country. A quality of a human resource produced by country's medical education system is determined by some appropriate government support in terms of policy framing, in terms of funding, and also some regulatory mechanism. As you all know, the most important is the regulatory mechanism. As you know, the regulatory mechanism of every specialty, every science has some regulatory mechanism. For example, for medical graduate, we have a Medical Council of India. For dental graduate, we have a Dental Council of India. Similarly, for nursing also, we have a Nursing Council of India. So we have to go by those, this is the regulatory mechanism, but they are not the controlling authority on you. They just could regulate our curriculum and all these things. But so these are some basic things while you're talking about things. Now, in this era, to impart a quality medical education, because this is important as because we need some manpower now. We need some human resource, doctors, paramedics, including nurses, technicians. Now to impart a quality medical education, to deliver effective education, we need to set up some distance learning mechanism. Now the question arises, now is it feasible to introduce the distance mechanism in medical science? There are a lot of questions. I am facing most of the time, because as we are starting, and Gati ma'am will speak and Ankuman will speak, that we are trying to give a education to the people by a distant mechanism like web classes and the Zoom classes, etc. But now, is it what's in a medical science or not? Because you all know that our education, we are giving our training, basically it is a mostly practical based. It's a practical, it's a lab oriented, it's a clinic oriented, it is a field oriented. So many things you need. So it is feasible in the medical science to impart this distant learning technology in medical sciences. It is possible, I'm sure. You will agree with me, it is possible in some humanity or some arts, or even some basic sciences. It may be possible, or even in engineering also. But in medical science, I think there is some lacuna, and some series, some more challenging in compared to the other specialty. So that part also we have to look at. But however, we are trying to manage our manpower by giving some distance training, giving some distance, education to our students. For this effective manpower, when you talk about our manpower, even now in Assam, not only in Assam, I'm talking about India, we are further increase our pool in a human resource. We all ask all our final year MBBS students to come and join in very first day, in the month of April 1st also. We call them that you come to the hostels. You don't go out of your hostels. Don't go to your place, native place. First year, second year is okay, they can go. But the final year students, we call them to stay in the hostel so that we can utilize your services. Right. Accordingly, we prepare them. Our medical college team trained them, taught them about what is corona, what is the COVID-19, how to deal with them. So that way also we are preparing. Similarly, in other aspects also, in the nursing also, the final year nursing students, even basic nursing, all nursing students, we say that your nursing students, your theory is off, but your practical is not off, because your practical is in the ward. So we have to work in the wards, but definitely we'll maintain that social distancing with maintaining all those other parameters. So we make them to work even on our these critical junctions. So still in our medical college or in our health institutions, they are working. Even the students are also working in the class, in the ward. So these are about some of we are doing, but there's still some need. There's some still need, because there is a shortage of manpower, because COVID is a different situation, not like in any other disease. Because here, every time after a group of the doctors or paramedics, they have to go for a certain period of quarantine, and this is mandatorily they have to go for a quarantine. So gradually, definitely there is a shortage of manpower, and it is increasing day by day because some of them catch some these infections and then they have to go for a longer time of quarantine. So similarly, we are facing, those are some of the very difficult situations we are facing right moment, but somehow we are managing. So that is one important point. I think Dr. Ankumani might be telling us, might be in a better position to tell us about those things. So in a end, just I'm telling you that we are in a very difficult era, really, and a very tough time for us now. It is very, very challenging. Now, how to manage the manpower, how to manage the structure, many of the institutions, many of the various health institutions to take care of our COVID patient. So with this opening, I'm opening this discussion, and in between I might interfere. In between I might interpret some of the comments from our esteemed teacher. I'm sorry, esteemed our speakers. So I may now leave it to Mr. Bhattacharya, please.
Thank you, sir. Thank you so much for your words, which are very much true, and we have to face this challenge and come out with various strategies and solutions. So moving on to our next respected panel member, Professor Dr. Gayatri Besbarua, Department of Pediatrics, Guwahati Medical College and Hospital, Guwahati. Before that, I just want to give a brief introduction of Madam's profile. Madam has completed MBBS and MD Pediatrics from Guwahati University, and then she has joined in the AMCH and GMCH department, like after AMCH to GMCH in the Department of Pediatrics from 1989, and served these various as a registrar, as assistant professor, associate professor, and now she is the serving as the professor, Department of Pediatrics in GMCH. Speaking about her administrative experience, she was the first registrar academics of Srimanta Shankardeva University of Health Sciences, Government of Assam, from January 2010 to 2015. She has served as HOD of Pediatrics, Guwahati Medical College from 2014 to 17, as an UPSC subject expert for assisting UPSC in various interviews, personality test boards, paper setter for National Board of Examinations since 2017, member of Specialist Board of National Board of Examination in Pediatrics for DNB, member of Supervisory Board of Prenatal Diagnostic Techniques, Regulation and Prevention of Misuse Amendment Act. She's a member of Selection Board of Selection of Faculty Members in Medical Colleges of Assam, Arunachal Pradesh and Mizoram. She is a member of Executive Board 2017 of East Zone, Indian Academy of Pediatrics. And also, I'm glad to say that she went to Sweden on a Rotary exchange. She had been to Sweden for a project, and she has a vast teaching experience of UG and PG with MD and DCA students during the working years. External examiner for undergraduate in states of Manipur, Meghalaya, West Bengal, Bihar, Gujarat, and also for PG examinations in state of Manipur, West Bengal, Bihar, Gujarat. She has other experiences, like she worked as assistant research officer in AIMS, New Delhi in ICMR scheme, in-service training program in neonatology in Maulana Azad Medical College in Delhi, trained in neonatology in Sweden as a member of group study of exchange program, as I said, in Rotary International in April 1997. She has a member of professional societies and other activities, life member of Indian Academy of Pediatrics, National Neonate Forum, life member of Pediatric Hemato-Oncology, Growth Development Behavioral Pediatrics, member of Adolescents Health, past president of IIP Guwahati branch, member Rotary International. She has number of publications, international and national. So it is indeed a great pleasure and honored. We are honored to have you, madam, amongst us. Thank you for sparing our time. And I am handing over the screen to you, madam.
Namaskar. Thank you very much for this opportunity to participate in this. I am really thrilled that Assam Downtown University has done something like this, because this is actually something we needed to talk about. I appreciate being invited, and I send my greetings to past District Governor Dr. N.N. Datta sir and to Baido, because they were responsible for a lot of things that I'm going to talk about today, because I saw it first in Sweden, and there's no reason why we can't do it in our country. I am going to talk in a slightly different angle. We are always talking about what we are supposed to give at the healthcare system outside. I am actually now bothered about the undergraduate students we are training and the postgraduate students that we are training. And I'm very happy to say that as soon as this problem started, the first thing was that we got a notice from respected DME, which said that please start e-classes. And it took us a little time to understand what we were going to do, but it went on full swing. So I am not going to talk about what will happen in the hospital, the decreased staff and the other things, but I am going to talk about this because if we are to have the WHO 1 to 1000 by 2030, we will need nearly 20 lakh more doctors by 2030. So we can't stop it. We have to find other methods. We have already gone into E-line. We have to think about what else we can do. And this is actually an unprecedented time. Let us accept it. A lot of things would not have happened if COVID had not happened. We would have not gone into E-line classes like we did. And it is also true that COVID pandemic basically goes for care of the patients and the communities. But it has disrupted medical education, and that requires intense and prompt attention from medical educators. And here we are talking about the student. Can I have the slide, please? Because the students themselves may potentially spread the virus when they are asymptomatic and they are coming as students, or they may acquire the virus when they are training. So that precaution I am not going to go in. What I am going to stress on more is that we will need lots of doctors more. We can't say no to them. And we also have to understand that we will have to change our teaching techniques. So we had a very good pedagogic system of teaching our students. We followed the didactic method. Hands-on integrated system was also followed with the Socratic method, which is very good for us. We also went into the problem-based learning discussions. So education is not what it was for us. It has changed rapidly, medical education, even in a country like ours, it has changed and we have to change with it. So the COVID period has actually given us a push to change our systems in a slightly different way. Now, when we started taking these e-classes, we started realizing the power of e-learning. And we also started understanding that we are talking about technology enhanced learning, where technology is used to support the learning system. And though the pedagogy is usually not part of the definition, some people use it. And e-learning as it is becoming important because you have personalized information and you have simulations or models which can be used. And we should not think that simulators are not used in India. They are used very well in India. We just have to make slight changes now. And communication tools have become different. And we have also now electronic devices to assist disabled learners. So how is education actually changing? When we do e-learning, as an old student with very good teachers, I will say that with e-learning, we miss the human touch. Medicine cannot be taught without the human touch. So how exactly will we go about it? Should we do it just the way we did it before? Or can we change a little? Not just spoke of it, but to enhance the type of education that we are giving our children in our country so that they can level out with the education that our students are getting in other developed countries. Knowledge transfer itself becomes much easier. We have very effective knowledge transfer when we are using e-learning. When we started taking the classes first, we had people contacts would go up to around 500, 600 people entering into the class. We thought that, okay, there must be a mistake. There may be other people not bothered. We started getting phone calls from people we didn't know. And they started saying things like, Madam, we were part of your class, or they would say, Madam, we were your past student. We thought we will see what you are taking. This is not there. Where did you get it from? Which textbook should we read? So it became an open situation where we started getting a lot of contacts from people. That is probably the first point that COVID-19 has pushed us, that we start using e-line education in a more practical and pragmatic way, so that we will do a lot of teaching there. The teachers will then have to start adapting to new options. And this adaptation will start taking CD-ROMs, computers, mobile phones, all this will come into the picture. But the other side to this is that the education and the class that is taken by the teacher has to be very, very specific and has to be with the times. We cannot teach something which we just taught or we just learned if it is not with the times. So the forum will change, and we have to be very critical about what we are saying to our children. We've already heard a big talk about telemedicine. It's used here, and it is being used more and more now. And with telemedicine concept, we know that there are a lot of things which we will have to manage. And for that, we now have a very good telemedicine network in our country. And this ISRO's network, with a very good attachment now to the Northeast, we will have to understand that there will have to be a lot of hand-holding when we are talking about healthcare education. Though I'm using this term in my way, I am talking about students that we are teaching to be able to take healthcare there, whether it is the undergraduate student, whether it is the dental surgeon, whether it is the nursing staff, or it is a paramedical student. Everybody is equally important, and everybody plays a very, very important role. We can't skip anybody. So internet, I will not go into because I will not have the time. But I am going to go 2 minutes left. Okay, I will just skip little bit, because now all over the world, there is something called flipped learning. So what happens is, what had started here now with the e-learning, the students learn at home, and then they will participate with the teacher. So here what happens is that, interestingly, it is now called school work at home and home work at school. So here, the important thing about a flipped classroom is, the first important point here is that pre-class material will be given for preparation. So the student will be told that next class will be on febrile seizures. I'm saying that because that's what I take. So it's come automatically. So by then, I will have to send that material that I am going to take or teach to them through the internet. They will go over it. They will read the books or whatever else they want. They will then have a fixed time where there will be discussions about that. So this is important. The next point I want to go in is the use of simulators. Because as we cannot touch patients now, we are going more and more into simulators. Simulators, I'll not go into the details. There are three main types of simulators. The first is the low fidelity simulators. These are used all over developed countries, where you will know how to put in an injection, how you'll tie a tourniquet, how you'll put a plaster. All that is done in the low fidelity simulator. Then you have medium fidelity simulators, where there are particular instructors who are trained, who will teach the students on how to do certain procedures. And there, whether it is how to give cardiac compressions or to do other things, they will teach there. So this is a medium fidelity simulator. Then you have high fidelity simulators. So high fidelity, I will not go into the details. We can see it. It's like a human lying there with everything. And this is the first time that I saw it was in my last visit to Sweden, when I saw this, and exams were taken on this. And the student was shouted at because they said, look for something else, look for something else. And they said, what else? Then the teacher said that this patient is sweating. This patient is in failure. You didn't notice that the patient is sweating. So simulators have gone to that degree. DME sir is sitting here. Can we get simulators like this? It's expensive. Maybe we will at one time, it will come. But let me show you what is happening in our country. Full-fledged right up to the periphery. Neonatal resuscitation is taught with a simulator. It is taught with a beautiful mannequin where we teach everything, including positive criteria ventilation, endotracheal intubation, cardiac compression, everything. So if we can do it at this level, we should be able to go to the other level. I think I have crossed my time, but the only other point that I would like to say is we have to think about how we will assess. We have had online exams also because of DME sir, 6th semester and 8th semester, I know they've sent us the papers. Certain places, AIMS has promoted students to the next semester without taking exams. We will have to start using our internships very well. And MCI rules for examiners for undergraduate and postgraduates have also changed. So it's a changing world. Mankind will come out of it, yes, but business is not as usual. Thank you.
Thank you, madam. Thank you, madam. Thank you so much for the informative, very much informative session, and showcasing us the positive aspects of the digital transformation, how simulators can be used for the challenging transformation of education in the medical science. I think in the coming days and the future, these technologies will surely merge in, considering the need of the hour. Thank you so much, madam. And moving ahead, we have our fourth panelist. She is Professor Dr. Ankumani Saikia, MBBS MD, Community Medicine. She is presently the professor and the head of the Department of Community Medicine, GMCH, Guwahati Medical College, Guwahati. She worked as a registrar, Srimanta Sankardeva University of Health Sciences, and she has a vast 25 years of undergraduate and postgraduate teaching besides PhD guide under Srimanta Sankardeva University of Health Sciences. She is the academic faculty for the course of PG Diploma in Geriatric Medicine under Indira Gandhi National Open University since 2004. She is trained on preventive geriatrics and International Institute of Aging, United Nations, Malta, as UN-sponsored candidate. She is the state nodal officer training for COVID-19. Also, she prepared the training manual on COVID-19 for the state of Assam. She is the master trainer of national programs like National Vector-Borne Disease Control Program, International Classification of Disease 10 and ICF, Infant and Young Child Nutrition, master trainer on infant and young child feeding counseling, WHO's program on disability prevention and rehabilitation, public health preparedness and response to Ebola virus disease, WHO advanced training on ICF, master trainer on casualty assessment of AEFI. She is also guest faculty in different workshops, CMEs, and conferences at the national and the state level, a contributor of chapters in textbooks, 4 books, 10 chapters, namely Modern Textbook of Forensic Medicine under JP publication, content writer of example Pathshala under UGC, Ministry of HRD, medical writing JP publication IAPSM textbook of community medicine, professional membership of various professional bodies, editorial and board member and reviewer of reputed national and international journals like Indian Journal of Basic and Applied Medical Research, International Journal of Health Research and Medical Legal Practice, Journal of Medical Science and Clinical Research, KNKU Journal of Medicine Science and Clinical Research, Indian Journal of Community Medicine, also reviewer of BMJ Open Access, Journal of Population Aging, International Journal of Health Research and Medical Legal Practice. She has done important publications in national and international indexed journal, around 30 publications. So I think she'll be the best person to let us or enlighten us about the COVID-19 scenario, which we are discussing, the reforms in the healthcare education and the post-COVID and the industry front. So, Madam, it's an honor for us. Once again, I heartily welcome on behalf of Assam Downtown University. I'm offering the screen to you, Madam.
Thank you very much.
Yes, Madam. Yeah, we can hear you. Thank you. Thank you, Madam.
Thank you very much for the detailed introduction. Eminent speakers, Dr. Udayan Borua, DME, Dr. Anup Kumar Barman sir, Dr. Gayatri Bes Borua, Professor Pediatrics. A very good evening to all of you, and good evening to all the participants. Actually, I would like to thank the Assam Downtown University for taking up this important and very relevant topic. Actually, it's a challenging topic, as DME is the right person to discuss all those things because it is related to health education. So anyway, I thank you all, and especially giving me this opportunity to speak a few lines, because although we know so many things about the digital revolution and how we can go for the digital teaching and all, e-learning and digital teaching, but how difficult is in our situation, that is also, and you have to know how to cope up with the situation. And you all know that COVID is, it's a catastrophe to all human population. It's catastrophe to the humanity. In that scenario, we have to relearn, and you have to learn how to reintegrate our entire healthcare delivery system. If you want to change our healthcare delivery system, the entire healthcare staff and their training has to be changed. And when I say healthcare staff, it doesn't include only the doctors and nurses. It includes a huge group of professionals, allied healthcare professionals. I give my salute to those allied healthcare professionals, because they are the front liner. They are working from the very front, even at this period of time, COVID crisis, starting from lab technicians, starting from other workers who have been really working hard since the beginning, along with the doctors and nurses. So when I say healthcare staff, basically it includes everyone, starting from doctors, nurses. And when I say health education, because I work also in the university, not now, but I worked in the university. So when I said there are so many allied professionals who are directly or indirectly contributing to this war in this crisis period. So basically, I'll be speaking on what are the different challenges we are going to, because as Barman sir has said, COVID is not likely to leave us, and we have to adapt ourselves to live with the COVID. So that's the issue we have, and we should not be feel like one day COVID will go and we'll get back to our normal life. No, it is not possible, and then we have to adopt a new normal life of learning. Now, if you see the education system, other education system, you can have e-learning and all. But if you think of medical education or health education, in that scenario, health education is not only the skill and competencies in clinical care. Health education also includes the development of personalities, interpersonal and interprofessional relationship. And then, the basic instinct in any healthcare, basic instinct is the relationship. Now, how to teach the relationship through this digital networking or digital platform, although as Gayatri Baido has said so beautifully that there are so many scopes for digital learning. but how much it that will be useful in our situation, in our scenario, to address the huge staff of all healthcare professionals. Just think of a physiotherapist. We'll have to, when a physiotherapist enters a room with a patient who is a stroke patient lying in the bed. Now the mere presence of physiotherapist should actually contribute something, a positive vibes. But whether that vibes can be taught through the digital medium, because when you interact personally or individually or face to face, the virtual medium is sometimes, although it is we have no option, but sometimes there is some problems are there with virtual mediums, especially in health education and especially in medical education. The future of learning, especially in medical education, you can say it at stake, especially for developing country. And then Anupda will agree with me, because organization of everything, like, it's not only, that is why I'm telling you, it is not only medical education, it is not only the nursing education, it's a huge group of the workers who will be trained, who will be giving education through the system of this system, although we have different councils. Now that is why I'm telling the healthcare is not only about this education of the doctors and nurses. We have now, it's a high time to think like how you rebooting, how to do, how to go about. Now COVID-19 has taught us one thing, that we cannot neglect public health. Even in every curriculum, even it is suppose a physiotherapist, a lab technician, even a nursing, even an ICU technician should know something about public health. And this is the high time. And then I think MCI will integrate all those things in, and the other councils also integrate all those things. Those are the basic things we have to follow in our coming days, coming years, not days. It will be coming years, maybe, for the uncertainty. Now it's a high time to think like, are you giving enough importance to our allied healthcare professionals or the allied healthcare education system? This is a time to think about. And then the professionals, are they trained enough in the basic public health preventive strategies? And at the same time, are they trained, whether their curriculum have been reviewed periodically or not? Although we have been, actually, when Anupda is there, we have been working on those issues like curriculum but in COVID-19 has given some new inputs, like, no, we have to add something very practical. Everyone in this country and everyone in this world should know the basic public health preventive measures. And one day, a day will come when everyone will be a warrior, irrespective of their profession. So that is why those things should be in the curriculum. So there are basically 4 points. One is the curriculum design. One is the mode of teaching. Mode of teaching is taken, I think, beautifully have taken up by Gayatri Baidu. Accessibility and adaptability of new methods, that is very important. We can say like there should be digital revolution, but whether it is going on or not, because we have been taking undergraduate classes, and then we have to now review like how many of them actually could have accessed the classes and all. Now, accessibility and adaptability of new methods is an issue, and we have to think of those. And then assessment part, which is very important, real-time assessment of the education system or the learning methods. Now, these are the basic things, 4 principles. On this 4 principle things, I will talk about on the challenges. Now, what is the basic challenge is that medical education, I am telling already, medical education is not only the clinical skills or technical part, it is basically the communication, interpersonal communication, interprofessional communication, and then the development of personality. So whether we will be able to deliver all those points in the system, in the e-learning system, and then basically I think we will have to develop it. We will have to develop those modules accordingly. In the locally also at the state level, for each level of teaching category, each level of workers. Now, again, the teachers and students needs to be oriented. They should know how to handle the digital format. Frankly speaking, I am also not too much used to all those formats and digital technology. So now I will have to start learning. So these are few challenges in front of us, because that is an issue, because if teachers, and then we must get support from the technologists as well as technology. Now, most of the time, even in the medical colleges, we are not getting the internet connection. So in that case, how can you expect that the people who are suppose any other allied healthcare professional sitting in a district, remote district, they will get the access to all the internet facilities and all. Now, MCI recommendation is early clinical exposure for undergraduate student and clerking, and then curriculum on virtual format will be coming up very soon. I'm sure they are working on it and it will be coming up. But the assessment is of course a challenge. Now, how to fill up, how to address all those challenges. This is an issue now. Now, if you see the solutions, what will be the solutions? Now, first is the curriculum design. We have to move from old school thoughts of school education. We have to move from the shock-based, board-based education now to digital technology. But in that digital technology, as Gayatri Baidu has said very specifically, the things should be very specific, and we need to reduce the curriculum. Now, if I am talking about my subject, there are 3-4 books, and all books are so voluminous, which is not possible for digital curriculum technology. So we must reduce the curriculum, and then there should be a board. DME sir is there, so I'm just taking the advantage of presence of sir. Yeah, we must have a board along with the guidelines of the MCI. We must reduce the curriculum to an extent that has been already started by Italy and all. They have already reduced their curriculum, and then basic point is what are the core knowledge they require. We have to be focused on the core knowledge, and then how to impart the core knowledges, that is very much required for this new curriculum. And second, all the curriculum, they must have a chapter on basic public health preventive measures. These are very important issues to be introduced in all curriculum, starting from doctors, nurses, everyone. Now, there is another point is, suppose a physiotherapist, he should know how a patient with COVID patient, what is the ideal position of COVID patient, whether it is a lie down, whether it is a prop up, what is the ideal position. So they should be taught in those points very specifically. Now it is whatever the technology we are going to use, the technology should be adoptable, technology should be accessible. That's a very important question. Like if you move ahead with the technology, with the digital revolution, at the same time we have to think of those people who will be taking classes from the remote areas, or who will be getting the knowledge from the remote areas. Now, what I believe is smaller things, bigger impact. Because public health is like with hand washing, if you can prevent like COVID-19 type of pandemic. So basically you have to go back to our basic instinct, smaller things, bigger impact. Now in the smaller things, bigger impact, what I feel like, if you use some use of real-time video, suppose Gayatri Baidu is taking care of a child pediatric case, if the Gayatri Baidu can take videos on that, and if that video can be circulated in groups of people with interaction, I think that will be more useful. And those are the issues and some most important issues, practical issues. If me or Gayatri Baidu, if we can start from the beginning, how to deal with a live patient. It's not like the simulation, live patient, and you put on record and then play the video along with the group classes on over Google or Google Duo, whatever. So I think that will be more useful, because in India, a country like India, we cannot expect that each and every district or each and every medical colleges, because every district are going to have medical colleges. So in that case, we cannot expect like this type of facilities, super sophisticated facilities will be there. But you can do these things which are very easy to do, and because I believe smaller things and bigger impact. Now, artificial intelligence is the option, and I think it will take time. Robotics is the option, it will take time. But what we can do, what we have been doing, even in our exam also we have done, because what we can do, we can put some exercises, it's like case scenario, like in COVID-19 cases. So we can put a case scenario, like what is happening in reality. So we can put it, and we can allot or we can ask our faculties to give at least 5-10 case scenario. We can distribute the case scenarios among the students, maybe doctors, maybe nurses, maybe physiotherapists, maybe laboratory technicians, and see they are the frontline workers. and then putting the videos with the case scenarios and then discussing the case scenario in groups, I think it will be the most feasible and most efficient e-learning class for a country or for a state like Assam. So I think I don't like to, and then there are two things which I would like to tell. One is that we have in this epidemic, we realize that the government has realized, the public has realized that two things are very important. One is the frontline worker, one is the public health cadres. So even in the allied healthcare professionals, if you can introduce a group of public health cadres, which can at least in this type of pandemic, at least can come forward and work in the organization like IDSP. And Unubda is the, I know what the hard time Unubda, our DME sir has been going through over the last 3 months or 4 months, because it is our staff. We don't have the adequate staff in IDSP. If you can train public health, we can put public health cadre as allied healthcare professionals. You can train them in the basic management like contact tracing, like how to take a swab, like how to make community awareness programs and all. Ultimately, I think this is a great idea, and if you put all this into practice, I think one day COVID may go, but another virus may come up. So we'll be able to handle all type of viruses if you introduce that type of. Now it is the high time to take out some courses which are not relevant and put in some courses which are most relevant in this time. And I'm again telling, COVID is not likely to leave us. COVID is really will be living with us, and we will be living with COVID or COVID type of illness. So we must get prepared. So with this, I just want to wind up because I think everything has been taken by our previous speakers. And so I just want to wind up, and I'm really happy and appreciate any questions. If I would appreciate any questions. And thank you very much for giving me the opportunity. Thank you.
Thank you, madam. Thank you so much. And as I can see, I think there are not any questions available. Hello. Yeah.
Yes.
Am I audible?
Yeah. Yeah.
Yes. Yeah. So in this short period of time, within 1 hour, we are discussing, and we have tried to discuss a very important and a mammoth task subject about the whole reforms in the healthcare education and industry front. And all the speakers, I think all